Good afternoon, everyone. I think we might make a start. Welcome to this last Pal-spectives of the year. My name is Jenny Phillip and I hold the Chair of Palliative Medicine at the University of Melbourne and St Vincent's Hospital, and it's my very great pleasure to be welcoming you on behalf of Palliative Nexus Group, who run these Pal-spectives sessions. If I can begin by acknowledging the traditional custodians of the land. We're all on different lands this afternoon, but I'm currently on the land of the Wurundjeri people of the Kulin Nations, and I pay my respects to elders past and present. I'd also want to acknowledge any Aboriginal and Torres Strait Islander people who might be as part of this event this afternoon. You will remember, I think many of you, that during all the lockdowns and things that we had in Melbourne over COVID, we sought to find new ways of coming together and being a field and sharing and I guess enjoying the work that different people do and hearing about things. So the Pal-spectives series was begun at that time, and we have now sort of almost established a tradition that at the end of the year we have a panel discussion, and today is no exception. So we're going to be joined by some wonderful panelists who I'll introduce in a moment. But I wanted to, I guess, set the scene for why barriers and bridges, the theme this afternoon. And thinking this through, I guess our world, in lots of ways seems ever more divisive. There are lots of factors behind this, and social media is not an insignificant one. A lot of our interactions and our conversations and our politics is increasingly conducted on social media. And as you know, it uses algorithms to respond to our patterns of behaviour, and our responses are used to tell us and to make us sort of link with people who are similar, are like-minded, and tell us more about ourselves and our views. As a commercial enterprise, it feeds us advertising, and simultaneously we know that people buy more stuff when they're angry or upset. So there's an imperative with the social media platforms to tell people things that will outrage them, and often things about the other. So creating the other seems to be an important part of this. And we live on our phones ever more, and we're increasingly part of this culture of sort of shoutiness with no public square, so to speak, to talk to each other. And it's in this environment that we are doing palliative care. And in lots of ways, palliative care is really the antithesis of this. We seek to engage with people, whoever and wherever they are, and their families, and we see communication as one of our core therapeutic tools, aiming for that holism of care. But I wonder if in the environment that we're in, whether our holism is being challenged. Palliative care is, after all, being asked to do much more than what it was asked when it was first developed, at least in the modern era, when it was largely based around inpatient units at the end of life. How is that holism holding up as we provide care across different settings, where maybe there's different drivers of care, such as in the ED department, or different funding models that are particular for particular interventions? We're providing care across different diagnoses, across different cultures, and even within palliative care across different arms of the service. So how do we hang on to the holism of palliative care in this environment? And to think through this and to talk with us this afternoon about this, we're joined by a panel of people with really deep experience and coming from a range of perspectives. So I'd like to introduce our panel for you this afternoon. First of all, Associate Professor Mark Bowie. So Mark will be known to many of you. He's the Director of Palliative Medicine and the Deputy Director of the Centre for Palliative Care at St Vincent's Hospital in Melbourne. He has many years of experience in the palliative care sector, with leadership positions within the state, national and international organisations and programs. So welcome, Mark. Dr. Rayan Salamusa is the Cancer Symptom Trials Postdoctoral Research Fellow and also the Acting Manager, National Manager of CST, Cancer Symptom Trials, and PACS, which is the Palliative Care Cooperative Trials Group. She's based at UTS in Sydney. She was awarded her doctorate in the area of cancer therapeutics by the University of Sydney, but made the transition from basic science now to more clinical research. And a significant part of her postdoctoral research is focusing on improving the preclinical to clinical pipeline. She's also, amongst other things, leading a project to improve diversity and inclusion in clinical research, with particular focus on underrepresented communities. So welcome, Rayanne. Associate Professor Violet Platt has been CEO of Palliative Care Victoria since mid-2020 and also holds an adjunct academic position at Edith Cowan University. Violet also has extensive experience in cancer and palliative care nursing across the UK and Australia and the Isle of Man. And I wasn't sure if the Isle of Man is also part of the UK or not. No, okay, so there you go. Thank you. And has also, for 14 years, led the WA Cancer and Palliative Care Network, influencing state and national programs. And in 2016, she was presented with a Lifetime Achievement Award in recognition of her contribution to cancer and palliative care. And finally, Associate Professor Hilton Gott is a staff specialist in nephrology and general medicine at St Vincent's Hospital, with again extensive experience in the delivery of medical care to high acuity patients in a teaching hospital environment. He has a doctorate in transplant immunology and has supervised both laboratory and clinical research PhD candidates, including those working in palliative care. And he has a long-standing contribution as a teacher and academic, and also as a contributor, being a long-standing chair of the Hospital Medicines and Therapeutic Advisory Committee and Clinical Policy Review Committee. And currently he's undertaking a six-month sabbatical in palliative care medicine, so has a unique perspective from both sides of the barriers, if you like. So welcome all, and thank you very much for joining us this afternoon. So I wonder, just to sort of set the ball running, if you like, I wonder if each of you might respond to what you think is one or a couple of really key barriers and challenges that you see from where you sit to the delivery and receipt of integrated holistic palliative care. So I might throw initially, Violet, to you, if I may, from a policy and from where you sit, all your perspectives and all your hats.
Yeah, and look, really difficult, as you'd expect, to choose one or two barriers or challenges. But I think an overarching one for us in how do we become integrated and holistic in palliative care when we exist in a world of fragmentation. We know we've got a postcode lottery because services are established differently, but also we've got fragmented funding, we have state funding, we have Commonwealth funding, we've got services that work in silos, hospital community, regional, metro. We can slice so many ways of fragmentation, and yet we want to give this unified, holistic palliative care approach that is equitable and looking the same across the state. And also, as individuals receiving palliative care, we're all different animals as well, so we can't have that cookie cutter approach. I think at the bedside with the individual person, we're absolutely focused on that patient-centred care approach and the specific needs. And I think that we do get really creative there. And by what I mean by that is we find ways to work around the system and the barriers on an individual level to meet the needs of that person. But in effect, what we're doing is putting a Band-Aid on the barriers, and we're never actually adding them up into the system. And given that palliative care is less than 1% of the workforce, 1% of healthcare, and less than 1% of the budget, we really can't afford to lose the voice on the barriers and the challenges. I think the other side of it is that palliative care can't work in isolation, and that actually that social care space and integration with that and the community where the person's living is really important, because sometimes the challenge might be actually about meeting hygiene needs and reducing social isolation. And as palliative care, we can't fix everything. So how do we create those good partnerships in a world of fragmentation? So I I think compassionate communities and compassionate cities are starting to give us a license to develop in that space. So we all go in the journey, but I think there's a long way to go.
Thanks, Violet. Thank you. And that's really the sort of the bird's eye view of all of that, the implications of sort of historical development and, I guess, policy and fixing things on the run yeah, thank you. That's tremendous. Hilton, what's your reflection on that, of the barriers that
Thanks,
you've
Jenny.
done?
Yeah, thanks. I mean, I would say that right, fundamentally, just this simple understanding of what palliative care medicine is a significant barrier to opportunity for integrated holistic approach. And by that I mean there's a wide variation of understanding of what palliative care is across specialties, within specialties, and most of it is weighted towards a misconception that it's still in terminal care. And so if most people, if the general misunderstanding is that, and that's where bulk of the people is, that's where the bulk of referrals will be, where the opportunity is very limited. And as you move back from the time of death to the year prior, where perhaps that might be a sweet point of entry or partnership, well, there's fewer and fewer people, fewer and fewer specialties, and even within specialties, well, it's the exception rather than the rule. So from where I've sort of come from 4 months ago to what I know now, and then seeing the referrals to palliative care, there's so much missed, and the number of times I've seen the look on the Pal Care clinician's face, I'm thinking it, but I can't say it, it's on a daily basis. So I do think one of the barriers is just that understanding that it's not just terminal care, and that there's a significant contribution for both those values of integrated approach and holistic care, well, a year prior to death, and all the implications that come with it, getting life in order, a good death, mindset, and the whole package.
Yeah, thanks, Hilton. And it's amazing to think that even you, who are very, Palcare friendly, feel like you've come on a bit of a journey as well.
Yes, it's indeed. It's had a profound effect on the way I see things, the way I see myself, and having done the communications course, that worked in the consult service, PCU, the palliative care unit, community, and now the acute version of that. I vastly underestimated what I didn't know, and as you said, I'm on the friendly side, so you can see on this side of the fence what I could see in my colleagues and all the referrals we're getting to palliative care.
Mm. Yeah. Wow, thank you. That's I mean, I think we sort of know it, but it's really powerful to hear it from someone who's deeply embedded in both fields. Rayan, how about you? What would you identify as some barriers to this holistic sort of integrated care we're seeking to provide?
Thank you, Jenny. So as a non-clinician, I guess I'd like to firstly touch on the receiving end of palliative care, and particularly from an ethnically diverse perspective, I guess the biggest barrier would be the misconception around what palliative care actually is. Just as Hilton touched on, those misconceptions are not just amongst the clinicians or the different specialties, but also within our communities. And there is quite a bit of fear around palliative care. So at least from my own personal experience, having a very big family here in Sydney with quite an extensive medical history of several neurodegenerative conditions, cancer and autoimmune conditions, we have found ourselves in a position whereby several members have required palliative care. And as a child growing up, hearing the family discuss palliative care, it was always painted in a very negative light. And unfortunately, despite being a researcher in this field and trying to advocate and help the family understand that that's not what it's about, not much has changed until this day. So quite often the family or the individual would reject or delay that care until the very end, and they're not really truly benefiting from what palliative care has to offer. I guess the other thing if I was to go to the delivery side of palliative care, I believe there is quite a bit of work to be done around cultural awareness, around spiritual and cultural intersections that may impact the individual or the family's decision to accept palliative care earlier on or not. Even sensitivities around discussing end-of-life planning or advanced care planning, I do feel that we need to work closely with the communities that we wish to serve, as well as religious leaders, to ensure that we are approaching these discussions in a culturally sensitive and appropriate manner, as well as ensuring that the resources that we are developing, the information packages and the forms and whatnot that we are handing to our patients are appropriate. And I feel until we address both those barriers, achieving a truly integrated and holistic palliative care will be difficult.
Thanks, Rayanne. Yeah, it's interesting, isn't it? Because we who work in palliative care, I think I might be, generalizing, but, see it as quite a creative sort of opportunity. And there's bad stuff happening and there's some things that maybe we can do to be helpful. But as those people, we sort of get blamed as the thing, or, it becomes sort of conflated with the bad stuff happening. It's a really interesting sort of thing, and how we frame it differently to make it helpful is such a challenge. Thank you. And I guess I'm just sort of commenting on that juxtaposition of, how we see it as a positive, and it's as otherwise, potentially something to be feared or avoided at all costs. Thank you. Mark, what's your response to some barriers?
Thanks, Jen. And look, I think holism is under threat. I think I'm going to sort of jump on the helicopter a little bit again and take a pragmatic kind of service view. But there is real radio silence, I think, at the moment with government and funding agencies that support palliative care. And I mean that in the broadest sort of sense. When did we all last hear some sort of broad sectorial voice from funders to give us a sense of aspirational achievement, inspiration, maybe even raise our expectations to be what Violet's spoken about, to be more than what we are at the moment, and to sort of be challenged to not just sit on a level playing field, but really look at building capacity, capability, maybe even innovate in a broader way and integrate. So we've got things to aspire to see beyond our own services and to see what a bigger picture could look like for a, state, territory, all those sorts of places. So I find it quite disappointing that we aren't more in that space. And I think one of the spaces that are particularly pertinent to that is certainly around the impact of the sort of fully fledged now activity-based funding modelling. And I think in quantifying achievement and effectiveness as turnover and activity is a very poor measure of the effectiveness and the holistic nature of palliative care provision. So there's a couple of worries there. In many ways, I think, coming back to your first commentary on social media, I guess people look at social media and think they're looking at their individual kind of choices and individual ideas, but in many ways, as you said, social media the companies direct you to think and work through the algorithms to come to sort of their thoughts about what you should be thinking. And in some ways, I can't help but think this is a little bit coercive at the moment. There's other things that government wants to achieve under the palliative care banner around Australia. And I think, almost we're looking for certainty in uncertain times, but ultimately, I think, the one certainty is that people die, and we seem to be trying to do anything but find certainty in those spaces by not talking about these things and not preparing people through palliative care towards their end of life.
So do you think, Mark, in the sort of the funding fiscal sort of uncertainty that we've just battened down the hatches and we've lost some of that?
Yeah,
we're less willing to.
I don't know if organisationally and services want to batten down the hatches. I think we've been forced to batten down the hatches just by the nature of this shift in funding mechanisms over the last 3 or 4 years. And also, again, the silence that we don't get anything to aspire to. And we do within our own local services and our own health service, but we don't get the broader framing of palliative care from government or the people that you would expect to give us that sense of a sort of achievement, I think.
Thank you. Well, I wonder, Violet, do you want to take that up? Because I was interested in one of your sort of roles in advocacy to government. And given you're hearing lots of different pressure points and concerns and things, I wonder how that sort of like your role as trying to have a unified ask or a unified vision for government. I wonder how that sort of, can you comment on your reflections on that?
Yeah, I mean, building on what Mark's saying, I absolutely agree. It's a long time since we've felt welcome in that space or that we've had any opportunities of sort of good news stories, approaches, or the fact that we're even listened to be honest. In Victoria, we've been working quite hard through Palliative Care Victoria to build relationships between services and the department as the funders and actually sit around the same table and have a discussion, which hasn't been able to happen for a long time. And we did get a commitment from the Secretary of the department at the beginning of the year that we would in partnership review the palliative care and end-of-life framework, because that was last done in 2016. And we're a very different world now to what we were in 2016. We've obviously lived through a pandemic. We've got different workforce challenges. The last time we looked at the palliative care workforce in Victoria was in 2012. And so there's a lot of baseline things that have changed that we don't know. Back in 2017, the government estimated that we'd grow at 4% a year. And some evaluation work that we did a couple of years ago, we're actually growing at 11.9% a year, and we were already underfunded. So I think there's work to be done, but I actually think having that strategic review of what's our plan, what's our key policies, and what way are we going, that all the services agree on, as well as community and the person that needs palliative care, so that then when we are looking at funding structures and workforce, we're doing it in a strategic way rather than a wish list, because we've actually rethought where are we now in 2023.
Thank you. Yeah, so I guess picking that up, Rayanne, you've interviewed healthcare providers who've worked for people, worked with people with from different communities, including the Arabic communities. I wonder if there are reflections from what you've heard and what people have told you as part of your research that could be sort of things that would be, things that we should be taking up in palliative care practice, making ourselves more relevant and building that story that Violet's talking about to be able to present to government funders, et cetera, et cetera.
Sure. So the context of our interviews and our research was around improving diversity, inclusion and diversity in clinical trials. But of course, we've interviewed palliative care clinicians as well as oncologists and other healthcare professionals. And I guess one of the key things that key themes that comes about is, again, the research and health literacy gaps within the community, within diverse communities. And you know, if we were to look at specifically clinical trials, it's trying to explain to the community the need for randomization, the reason why we have things like placebo, and trying to explain these concepts in order to improve that participation in clinical trials. But in the context of palliative care, it speaks to that point that I made earlier around addressing the misconceptions and that fear. At least if I was to focus on the Islamic community, and this, I apologize to anyone on the line, this may be a trigger, but palliative care is viewed as almost as though clinicians are giving up on the individual, and giving up borders on almost suicide, which is considered a sin in our religion. And so that's where that, I guess, the question of is it permissible for me to give up and accept palliative care, or should I be pushing for continued treatment of a condition even if the doctors are telling me that it's not effective? So I guess by addressing those research and health literacy gaps, as well as the misconceptions around palliative care, we can then, I guess, work from the bottom up, work with the community, and work our way up to improving and creating policy changes. Yeah, that's basically the key themes that have come out from our interviews so far.
And key is working with the community, and I guess community leaders. Is that sort of I'm thinking about how you reframe palliative care in for example, the Arabic speaking community, how we begin to go about that. It's an important and a big piece of work.
Yeah, definitely engaging with not only the community leaders, but specifically different religious leaders. So again, the Arabic community is not just of the Islamic faith. There's a huge Christian Arabic speaking community as well. And so working closely with those different religious organizations to try and address these myths around what palliative care is, and how it may be of benefit, and you know, it's with palliative care, with the way I've understood it, you are preserving the quality of life, so you're not causing harm. But some individuals may view it as if we're stopping treatment for the condition, that you are then causing harm to the body, which then may be viewed as a sin. So yeah, just addressing those misconceptions in a culturally and spiritually sensitive manner, with the support of religious leaders, because we will need their support to get this message across.
Thank you, Rayan. And it's sort of it's that sort of never-ending cycle, isn't it? Because if people avoid or fearful to introduce palliative care early, then it is late, and then it is perhaps close to death, and then it sort of reinforces that thing. So, I mean, the answer of early palliative care seems like a good potential solution. You can still be having your treatment and also having access to some of the palliative care. But yeah, it's got to break that nexus, doesn't it, between the perception and the misperception.
Yeah.
Thank you. Hilton, you talked a bit about this before, but what's perhaps struck you particularly about the differences in nephrology versus you're now working in palliative care?
Yeah, I guess my role as an acute care physician, nephrology and general medicine and palliative care are almost at opposite ends of the pole. And I can give you a sense of how acute care has sort of evolved over time. So when I graduated, it was holistic biopsychosocial model, take a good long case, and everything is taken into account. A bit like palliative care on the mastery end. Well, ever since then, with the pressures of administration, tightened beds, high turnover, it's essentially been wringed out of me. And that's why I found it so hard readjusting to a holistic approach. Over time, having the expertise, understanding the patient at a cellular level, having all the drugs at my fingertips, on a post-take round, I could pretty much narrow down a couple of priorities to get the patient out, which is exactly what I've been doing, and being thanked for it by our administrators when they publish the monthly length of stays for my unit. And reinforcing that behaviour. And then, somehow the rest of the patient got a bit forgotten. The awakening has happened over time because I've noticed I've been stopping more drugs than starting drugs. And that's how this part of my journey began. And then on the palliative care side, once I've understood truly what patient value-based care was, quality of life. It's like having the rug pulled from under your feet. What the hell have I been doing for the past decade? And it's time to make amends. So it's in stark contrast, and I've been really reflecting a lot on how the hell do I go back to doing what I'm doing, knowing what I know now about how a patient can be properly looked after in that last year of life. I've already had the sense that this coming in and out of hospital, in and out of acute care, in and out of ED, in and out of ICU, only to have a death at the end that comes somewhat as a surprise, was wrong. I just didn't know that all the solutions are already there. The awareness within palliative care is already there. The communication skills and the education that could be taught to clinicians is already there. But the awareness on the acute side is completely just almost unknown. If you're unconscious of your incompetencies and you're unconscious of your competencies, well, how do you reach the mastery level? And I think palliative care essentially has that mastery level because of that awareness. But without that awareness in the broader medical and surgical community, that gap is formidable. So that's a stark contrast if ever I saw one. And like I said, I'm a changed doctor, and I'm a changed person to 4 months ago.
Gosh, Hilton, wow, thank you. Thank you for sharing that. That's really powerful. And I'm sort of struck also, as you say, that there's so many incentives to be sort of practicing, in particular ways. And it doesn't, perhaps loops back to what Mark said, is that the measurables of this other way are not so readily available to sort of systems, perhaps.
Yeah, so I've summarized micro steps that have happened over 15 years, and each step, all the clinicians, best of intentions of administrators as well. Each micro step has just added up to, something, so far apart that it shouldn't have been.
Thank you. I wonder, were you going to say something, Mark? Sorry. No, okay, thanks. I might ask, because I know that that we have talked a little bit about, I think, Violet, you talked about, at the bedside, people make things happen despite all the splicing and dicing and the differences, but you find workarounds to just sort of make it work, and sometimes those are band-aids and sometimes they're inspirational, but workarounds nevertheless. But this is a creativity, and I wonder, Mark, I might throw to you. I wonder if you might comment on something that you've observed recently, where a response, maybe a small one, or maybe, you know, a big one, was actually a sort of a creative response to sort of a problem or a barrier.
Yeah. Thanks, Jenny. Creativity, it's always in the moment, and then trying to recollect, it doesn't always happen. But look, I'm thinking about one situation. So we still, even though I'm centred here at St Vincent in Melbourne, we still do supportive direct care visits in the Hume region of Victoria up to the New South Wales border. And I happened to see somebody up near Numurkah a couple of months ago, and a guy who, you know, reasonable health literacy, reasonable family, supporting family, but had been quite traumatised by an admission to the major regional hospital, which was Golden Valley Health, and that the traumas didn't centre around anything in particular, but it was just the sort of sense of, you know, bright lights, a lot of noise, little information, you know, unawareness, and quite traumatized to the point when we visited this gentleman in the home a few weeks later, he hadn't been able to sleep. And in fact, his recollection was the last 4 or 5 weeks of his life since leaving hospital was that he was so distressed from what had happened that he just couldn't sleep, and he was getting no sleep. That's what he spoke of. And this was quite disturbing to the family, quite disturbing to me, and to the supporting palliative care nurses that were trying to make sense of what this meant. And it had gone down the usual sort of pathways, looking at the psychological impacts and things. But no one had a real sense of what really no sleep, I can't sleep at night meant. Is he sleeping in the daytime? Is he sleeping, you know, but not knowing, and all those sorts of things. So I thought, wow, we're here in a remote area. The chances of getting anybody to unpack this, you know, we can't send him off to a sleep centre. That didn't seem a practical thing. So I thought suddenly out of the blue, while I was talking to him, I said, does anyone in your a family have one of those sort of medical Apple sort of devices, a Fitbit, or one of those things that records body movements and sort of can somehow justify sleep? And suddenly his daughter said, oh, I've got one of those. And so what we did was we got him for about 5 days in a row. I mean, I trundled back to Melbourne, obviously, after all of this, and that was one thing we looked at. And we got them in 5 days. And in 5 days in a row, it could demonstrate that he actually was sleeping, but whatever was going on in his mind, he would wake thinking he hadn't been sleeping. So that was the beginning of the sort of journey. Instead of moving towards medications, looking at melatonin, thinking about antipsychotics and all that sort of stuff, we moved to his realization that in fact it was centered around whatever that traumatization was, and somehow affecting his way of being in the world. So in some ways we solved the problem by suddenly being a little bit creative, a little bit modern, and not saying, oh, we can't do that because services aren't available to you and things like that. So it's quite a precious story from my point of view, and not that I've ever worn a Fitbit, but I will remember now that maybe it's something I should keep in my pocket.
Thank you, Mark. Thanks very much. Rayan, do you have a something that you've noted creative that may have built a bridge over a problem or a barrier from any part of your work?
Not so much my work, but I guess some of the other research that I've come across, or other ways of engaging with community to address, I guess, other areas of medicine and health literacy. So I've seen things, particularly in the Arabic-speaking community, where they've created theatrical productions around mental health to try and, I guess, bridge that gap in health literacy and raise awareness for mental health. There have been videos that have been created in languages, in specific languages for those communities, to a kind of like a drama series almost. And this was not an Australian one, this was a South American one. But yeah, there are creative ways in which we can engage with communities to try and address these gaps. And that's the only example I could really think of. Thank you, Jenny.
Well, the arts is a fantastic example, isn't it? It sort of bridges so many things all at once, doesn't it? It's tremendous. Thank you. Hilton, something creative you've observed, a workaround or a bridge?
Yeah, I've had a couple of observations that are good reason for optimism and of cultural change. One is from top down and one is from bottom up. From the top down point of view, physicians like myself gaining palliative care insights, or dual trained physicians are bringing back some of these principles back to the specialties and then influencing those in proximity. One example is, I'm not sure whether I can, it's very positive, our respiratory physician that's also palliative care trained, opening up a scleroderma clinic, where in scleroderma, it was treatment after treatment after treatment, biological, and then pass without palliative care involvement. And since opening up that clinic, well, it's gone up. Referrals have gone up exponentially. Not only that, the letters, and she actually showed me one from the rheumatologist, are starting to include some of the holistic principles of advanced care planning, patient preferences, and patient values. And I took, a very optimistic note of that can be influenced. She also showed me a letter from one of her registrars, which, apart from the usual letter, also included a separate section on patient values and advanced care planning. And so I think if that cultural shift can occur, well, maybe there's hope in preserving and expanding some of that holistic integrated approach and awareness over time. The other one from bottom up was from the communications masterclass that I did in Warn Pond, run by Deakin University, the Centre for Organisational Change and Person-Centred Healthcare. I have no shares in the unit or anything like that, but I was most impressed with the awareness, so much so that afterwards, for a separate reason, when they reached out, I jumped at the opportunity to meet up with the director and deputy and sort of gain a bit of insight into what they were doing in teaching their medical students. And so with those communication skills, I just imagine if I knew what I knew now, go back 25 years and have developed them, doing what I'm doing now, reflecting on every patient interaction with the communication skills, I think I would have been at the mastery level, no different to my medicine, except I'm a late starter here. I see the registrars and interns that are doing palliative care do integrate that into their practice going forward. And I was just having a conversation with Mark on that not so long ago. There's a cultural shift that's in evolution. So a couple of points of optimism.
Thank you. And I'm struck by that, the clinical relationships and the trust and how that can sort of really breed or foment change and practice change over time. But it is it's a slow burn, isn't it? Thank you. I'm a little conscious of the time, and we tend to always end these sessions with your reflections on a quote. And today I want to just contextualise it a little bit with something that I heard in an interview with Stan Grant, because I think it offers sort of some, I guess, a link between where we were and then perhaps what I'll ask you to comment on. So Stan Grant said in an interview talking about democracy, he is very worried about the state of democracy, and he said it requires intimacy, and we've lost in the technological revolution, what we've lost is intimacy. We're more connected than ever, but actually we never have to touch. So we can sit at home and order food, never have to see the person who cooks it, never have to see the face of the person who delivers it. We're losing the human touch. And, you know, there's something about in palliative care, that intimacy and that importance of the human touch. But in the same interview, he actually reminded us that Leonard Cohen said, there's a crack in everything, and that's how the light gets in. So, Violet, your thoughts on those?
I think we always have to be opportunistic. You know, the world is a technological world. It's also a lot easier to get around than it was, you know, a couple of decades ago, which means that we don't have those nuclear families that we used to have. I heard a statistic yesterday that 50% of people who live in Australia were either born overseas or has at least one parent that's overseas. So if anything, in this world of technology, we're more family isolated, or we're away from each other. But technology has been amazing in keeping us connected, and during the lockdowns, so many communities benefited from, you know, we had all the younger generations teaching all the nanas and granddads how to use FaceTime and make connections and seize the opportunity. But I think we have to work with the technology very much in a co-design way with the community, with the people that could potentially benefit from it, and deliver it in a way that works for them. We can't lose the intimacy. That palliative care is a very intimate care approach. We can't lose that. That's how we're patient-centred, how we create those relationships. We go through a very privileged time for that person and their family that technology just will not take us through. And we need to listen to that individual's voice, think about what we're doing. Remember, everyone's got the right to palliative care, ideally in the way that they want it and where they want it. So we need to really build on increasing the knowledge and awareness and confidence in the discussions around palliative care in whatever community, and we need to build on those compassionate communities. And Stan's quote to me when he talks about Leonard Cohen and the crack letting the light in, for me, he's talking of hope. And that made me think about Nelson Mandela, who said that hope is a very powerful weapon. And I think we've got to take that hope and use technology appropriately to our advantage.
Thank you, Violet. Rayanne, your comment?
I think Violet perfectly articulated a lot of the things that I was reflecting on with this quote. And I guess if I was to touch on one thing, it would be, I guess, in a world where hardships are unevenly distributed, I just want to take a moment to acknowledge the privilege that many of us share here, and that acknowledging this privilege is a responsibility and a call to action. It's a tool that we can wield to create positive change, and for us to act as catalysts for a more equitable and compassionate world. And so when Violet said everyone deserves access to palliative care in the way that they want it, that's I'm just thinking about that, reflecting on that from the ethnically diverse community perspective as well. So if I was to leave you all with one message, it is, let's carry our privilege with humility and a sense of responsibility, and let it fuel our commitment to advocate for those whose voices may be drowned out, because while many of us may be well connected through technology, there isn't equitable access for everyone, even with the technology that we have. And yeah, let's use that that privilege of ours to create a more connected world.
Thank you, Rayanne. A call to action and to do so with humility. Thank you. Mark, your reflections?
There's actually your dialogue and the quote, I think it makes me think of something that actually we witnessed on a ward round today out at our palliative care unit. And that's, I think, I was trying to explain it to our younger doctors of transcendence and that sort of expression of transcendence of a patient acceptance of one's own death. And it was quite a powerful thing to witness, because you don't often see those moments when they talk to you and talk to his family in that very open way. It's usually an internal process often. But I think our discussion today suggested, and what people have spoken about today suggests they're either not engaging in a timely way to the palliative care kind of domain, or we're moving further and further away of that sort of centeredness, our spiritual centeredness, true centeredness, not constructed centeredness, people telling us how we should be, but that sort of internal centeredness. And I think, in some ways our kind of social media generation is reaching out to solutions at the moment. Maybe it's with the psychedelics to sort of shake us up a little bit to find it, or maybe even VAD itself can sort of take a role in allowing people to be. But I think in many ways, as I think Hilton mentioned, the solutions are already there to some extent. And then, palliative care in its richest form, which can walk alongside these other sort of more newer modalities, but can be separate to be just, in its richest form, can, I think, indeed be that sense of transcendence and acceptance of death as his expression. And to me, that's the light, the crack, the light that, the shell, the light can be seen. And I don't mean that in a sort of godly way, but I mean it just in it's the reality of accepting palliative care as part of good care provision.
Thank you, Mark, because that's sort of creating the space in the way for that grace to happen, and being witness to that is an extraordinary thing. It's interesting that it's hard to talk about these things without using language that sort of immediately seems to have connotations, religious connotations in a way, which may or may not be relevant to what you're talking about. Thank you. And what a word round. Thank you. And so, Hilton, the final comment to you.
Well, thanks, Jenny. I mean, that just going by Leonard Cohen's quote, there is a crack in everything. And the way I've been seeing it of late is that, well, the fundamental practice of palliative care is the light that's getting in. That holistic approach, communicating with the patient, that intimacy that social media can never replace. I can think of many examples. I've had the privilege of shadowing all the Pal care consultants like a registrar, but being treated like a colleague, but watching each practice, that whole spectrum, and absolutely fundamental to the practice is that intimacy in the finessing, if you like, the patient's values. So I think, well, that is the light. That's not negotiable. It's part of palliative care practice. And I think a couple of examples that you can never replace with a machine was our palliative care nurse practitioner with a patient reluctant to come in, but came into acute care in his terminal phase, and he could only communicate with a blink and the sliders of nod, and with 7 questions face to face with the patient, he was able to get from the patient, well, he'll get his dying wish to go to the palliative care unit, which he knew about. There was a risk in dying. What would he like to do? And I got the patient across for a comfortable death right at the end. And how could you replace that with an SMS message? Well, you can't. So that's just an extreme example. But that communicating and understanding with a patient. For myself, I've been practicing various versions of the dignity question recently. 3 minutes or 5 minutes of listening, the amount I could gain in the patient's value that would alter my practice, active or palliative, if I can use that term, well, that is so basic to delivering that healthcare. So hats off to the whole discipline and the consistency across the discipline for being the light that's shining through the cracks of society, medicine, surgery, administration, healthcare.
Yeah, that's wonderful. Thank you, Hilton, and thank you, everyone. What an incredible discussion, and it's been so we've dissected, some of the entrails of what's going wrong, but we've also thought deeply and landed on some extraordinary things that I think are the things that keep us going and that we know are possible and are so valuable about this approach to care for people and for medicine. So thank you for saying that as well, Hilton. I would like to thank our panelists for this afternoon, Violet, Hilton, Mark and Rayanne. It's been a tremendous discussion and I really appreciate the thought and the wisdom and the care and also the courage for coming on, because I know that these takes a bit of thinking through and I really appreciate that and the time you've put in. I wanted to thank